Assalamu alaikum, everyone. Thank you very much for tuning in to our virtual free paper presentation. I hope everybody can hear me loud and clear. I'm Rehan. I'm one of the Rehan bin Asif complete name. I am a gynecologic oncologist here at Shaukat Khanum Memorial Cancer Hospital. Uh, we have this symposium going on today. Is the third day of our symposium, and I am so excited to share that the attendance, the thoughtful sessions, and the remarkable speakers I've been tuning into just amazed me. I am so impressed. I want to take this opportunity to thank all my uh, organizers, especially Dr. Asad Pervez, Dr. Sumera Bhatt, and the administrative people who've been pivotal in arranging this symposium at such a great length. I also want to thank all the teachers and mentors involved in this educational activity. You know, there's a famous saying that tell me and I forget, teach me and I remember, involve me and I learn. And that's how we learn. We are involving all our mentees and our trainees in order to encourage them and facilitate them to come up to the par. And I'm excited that this interesting session is about to commence, and I'm going to start introducing my first speaker. She's presenting her work. She's our astute fellow from radiology, Javeria Aleem. You can see, you'll be able to see her on the screen soon. And she'll be presenting role of diffusion weighted imaging in the evaluation of post-treatment tumor response and rectal carcinoma. So I'm going to hand over the mic to Javeria Aleem. There you go.
Assalamu alaikum everyone. Bismillahirrahmanirrahim. So, I'm Dr. Javeria Aleem, Fellow Radiology at Shaukat Khanum Cancer Hospital, Lahore. I'm going to present a role of diffusion weighted imaging in the evaluation of post-treatment tumor response in rectal carcinoma. So MRI is very important in determining the response or staging of the rectal cancer and difference between the tumor and fibrosis, and knowledge of specific pattern of morphology and diffusion signals help to improve the evaluation of tumor on MRI. Rectal cancer is third leading cause of cancer death in the world, and in this year it has been estimated 1,47,950 adults were diagnosed with colorectal cancer. And in Pakistan, among colorectal cancer patients, there is 85.4% heterogeneity. DWI importance is already mentioned in last 140 papers for the last decades, and the studies were conducted over 128 patients, and it has become guideline of European Society of Gastroenterology, gastrointestinal abdominal radiology, that DWI should be incorporated in every MRI examination. So in our study was conducted over the period of 6 months, and we included 200 patients, out of which 141 were males and 59 were females, over the range of 21 to 73-year age. And inclusion criteria was patient with the histopathologically proven rectal adenocarcinoma, abdominal perineal resection done before the start of our study, that is February 2019, and DWI ADC sequences along in the MRI was done before and after chemoradiotherapy. And those persons which were not included were that undergone upfront surgery without neoadjuvant chemotherapy and MRI imaging without DWI and ADC sequences. All patients undergone MRI on 1.5 and 3 Tesla scanner, and sequences were acquired T2 weighted sequences, T1 weighted sequences, DWI oblique axial, with DWI P factor range from 0 to 1000 second millimeter square. And average time interval between the post-treatment MRI scan and surgery was about 8 weeks. The important thing in description of rectal tumor on MRI is first to locate the tumor in relation to anorectal anal verge, that is the tumor which is located within 5 centimeter from the anal verge is the lower rectal tumor. Tumor located from 5 to 10 centimeter is a mid rectal tumor, and 10 to 15 centimeter is high rectal tumor. In our study, most of the patient had lower rectal and high rectal tumor. We determined T2 signals and DWI signals on both pre and post chemoradiotherapy MR scan. And most of the patient in our scan had moderately differentiating adenocarcinoma, with 25 cases well differentiated adenocarcinoma, and 65 patients had poorly differentiating adenocarcinoma. And most of the tumor were located in the lower rectum. Response was evaluated on the basis of the RESIST criteria. The complete response was determined when there was an absence of the measurable tumor volume with absence of T2 and DWI signals. 30% reduction in the tumor was labeled as partial response, while 20% increase in the tumor bulk was determined as progressive disease. No change or little change was labeled as stable disease. Also, tumor response was graded on the basis of tumor regression grade. Grade 1, no evidence of the tumor. Grade 2, good response with dense fibrosis. And grade 3 is 50% fibrosis and 50% tumor volume. However, 4 and 5 grade represents no response or little response. So in our study, out of 200 patients, 43 patients showed tumor response, while the 157 shows no response to chemoradiotherapy. Out of 43 patients, 28 patients showed complete absence of the tumor and signals, while 15 cases were false negative result. And out of 157 patients, 12 patients had stable disease, 38 had partial response, and only 7 patients showed progressive disease, while 3 cases were false positive. So these results can be determined on the basis of the graph, and the results were statistically significant. There was a MRI response and pathological response were correlated statistically, and the p-value was less than 0.005. We also specifically determined the overall diagnostic accuracy of MR, that was 91%, with sensitivity of 98% and specificity of the 65.12%. We also specifically determined diagnostic performance of DWI sequence in MRI evaluation of the tumor response, and we plotted ROC curve. This shows the accuracy of DWI in determining difference between presence of the tumor and absence of the tumor is 80%, as indicated by area under the ROC curve. So our results were comparable with the results mentioned earlier in the studies, and we also determined that mean value of ADC was higher among patients that showed complete response than in the patients with no response. But there are still limitations in MRI evaluation. First of all, DWI sequence has low spatial resolution and high B values. We are unable to differentiate between different layers of the rectal wall. And also, DWI cannot differentiate between complete response and near response or inactive mucin. So, in mucinous adenocarcinomas, DWI sequence is not helpful. This is a pitfall of this study. We have an example of a case 63-year-old woman with pathologically proven moderately differentiating adenocarcinoma. This is a T2 axial and the sagittal sequences that shows the tumor bulk along the right lateral wall with diffusion restriction. And after chemoradiotherapy, the tumor bulk was significantly reduced with decrease in the tumor's DWI signals, so that represent partial response. So DWI sequence is not only helpful in evaluation of the treatment response in colorectal cancers, but it also helpful in evaluation of nodal metastasis. So DWI sequence should be included in every MR of colorectal cancer before and after chemoradiotherapy. I would love to answer any questions if there are. So these are my references, and I would thank you, Dr. Imran Khalid Niazi, for helping with this
Yeah.
presentation.
I am Dr. Mohsin Fareed. I am one of the reviewers for your presentation. It was a nice presentation, Dr. Javeria. I have a question. Do you have a data on the duration after MRI to assess the response? Like, were they 8 weeks or more than that? Because that has a
No, I have.
correlation with the.
Sorry, I have mentioned that we have scans after 8 week and 12 week, and on average we have 8 weeks post treatment MRI scans.
Okay, okay. And did you do the DW sequence on all of them, or is it like a baseline and you follow them up with DW scans as well?
So we have a facility in our hospital that we do DWI sequence in every staging scan, but we are limited at the point when we receive scans from outside our hospital. So on that, so I have mentioned we exclude that patient from our study, in which
Okay,
a DWI sequence were not available.
okay, thank you. Thank you.
Thank you.
I have a question, Javiria.
Yes,
Excellent
sir.
presentation,
Thank you.
and thank you very much for bringing this work to us. You said that the accuracy is about 80%. Is there
Accuracy of
any
DWI.
DWI is 80%?
Yes,
So
overall
with
MR is 91%.
if with this accuracy of 91%, which is obviously very significant, is there any inter-observer or intra-observer variance in it?
Yes,
Meaning,
yes.
okay,
So that is why the accuracy is towards the 90%. So we have a lot of variation in even how the scan is operated. If we have blur images, then obviously there will be the interruption in the detection of the tumor signals, and also observer variation, how the person is experienced to pick up the findings. That
thank you very
definitely
much.
affects. Thank you.
Thank you very much. Appreciate your hard work.
Thank you.
Moving on to our next presenter, before I move on, um, we are in a learning environment, and you can see that a lot of this hard work is coming from the true teachers. And they say the true teachers are the ones who actually serve as bridges over which they invite their students to come across. And then, having facilitated them coming across, joyfully collapse, encourage them to create their own. And that's just the important part. A pivotal role in a society is of a teacher. And I can see that when they see these budding stars, these growing residents in front of them, these mentees, these fellows, it's just a sense of joy for them to see their own product coming out in the market. And when obviously they work hard and they shine in the market, in the society, in the community, uh, obviously all the teachers, myself, we feel so proud of them, so proud of them. um, I'm going to move on to our next presenter. uh, our next presenter is our surgical fellow, Nigat Bakhtiar. Thank you very much, Nigat, for coming over and presenting your work. And she's going to be talking to us about laparoscopic extralevator abdominoperineal excision for low rectal cancers. So over to you, Nigat.
Thank you so much, sir. Let me share my screen first. So I hope everyone can see the screen. Good morning, everyone. I am Dr. Dighat Bakhtiar. I am Fellow Surgical Oncology at Shaukat Khanum Memorial Cancer Hospital and Research Center. The topic of my study is related to laparoscopic extralevator abdominoperineal excisions. So, starting with the objective, the main objective of my study is to determine the outcomes of laparoscopic extralevator abdominoperineal excision for low rectal cancers. So, a few points introducing the topics. Rectal cancer surgery has been evaluated years ago. Initially, abdominoperineal resection was described and started by Miles in 1908. After that, another useful invention was of circular staplers, which was done in 1970. Later on, the concept of total mesorectal excision was first introduced by Heald in 1982. Keeping in mind the importance of total mesorectal excision, T. Holmes introduced the extra levator abdominoperineal excision in 2007. So before proceeding further, I would like to share the indication of doing abdominoperineal resections, and they are actually the patients with carcinoma rectum, who in which external sphincters or levators are involved. Other than that, patients with poor sphincter function. And another important indication for the surgery is carcinoma anal canal in those patients who failed to the neoadjuvant treatment. So initially, the conventional abdominoperineal resection was the only option for surgeons in the previous times. Unfortunately, there were some problems with the conventional procedure, like a high local recurrence rate and positive circumferential resection margins. Um, Other than that, there was a relative higher risk of bowel perforation intraoperatively, and morbidity of perineal wound, including hernia, dehiscence, and infection, was also a little bit higher in the conventional procedures. And the reason behind these complications is because of the poor visibility during the deep rectal mobilization, the poor perineal exposure, and that was majorly because of the positioning. Other than that, another important reason was that the resections were too economical, preserving the levators for closure actually. So, on the other hand, extra levator abdominoperineal excision has some extra advantages. Like we remove a larger amount of tissues, including lymphatics, muscles, and fat. And there is a better visualization of the anatomy because of the positioning. And we have less tumor perforation rate as compared to the conventional surgery. Uh, the difference in outcome is actually because of the difference in resection margin lines. You can see in the pictures that the small dotted lines are the resection lines, and the large dotted lines are the level at which the resection lines meet. So we go quite above the levator in the new procedure, that is the extra levator abdominoperineal excision. And because of this difference, the specimen which we get in the end of the surgery is also different in both procedure. In extra levator abdominoperineal excision, you can see it is quite cylindrical in shape. As compared to the specimen in conventional surgery, it is conical in shape, or you can say wasting of of a specific part, and that is the critical point where we can miss the mesorectum. So this study, which we did, was a retrospective study, and it was done in the duration of January 2014 to December 2019. Data collection was through hospital information system, which is electronic database system actually, and it was analyzed by SPSS. Another important thing that we discussed all our patients in multidisciplinary meetings. Regarding the procedure, I would like to share the basic steps of the perineal part actually, in which the patient position is prone jack knife position. You can see it in the picture here with legs apart. After that, what we do, we close the anus with purse string sutures. A teardrop incision is given around the anus, and it is extended cranially to the lower part of the sacrum, and that is given in almost all the patients. Dissection was continued just above, just outside the subcutaneous portion of the external anal sphincters. Levators were exposed circumferentially up to insertion, and coccyx was disarticulated from the sacrum. Higher up division of the pre-sacral fascia was done, then the pelvis was entered. After that, levator muscles were divided, and specimen was usually brought out and dissected off from prostate in males and posterior vaginal wall in females. So you can see the diagrammatic presentation of all these things in the pictures as well. And this is the end result, the white perineal defect, which we find usually in the end of the surgery. So coming to the important part of the presentation, that is the results. So there were actually 82 patients which were in which extra abdominal perineal resection was done in the given period. The median age of the patient was 39 years, and that is quite young. And after that, I would like to share that the neoadjuvant chemoradiotherapy was given to 96.3% of the patients. Actually, it was offered to every patient almost, but the three patients missing here were actually those of malignant melanoma. Our NOT resections were performed in 81.7%, that is 67 number of patients. Another thing I would like to share is that the preoperative tumor sizes were T2 in 3 patients, T3 in 64 patients, while T4 in 15 patients. While after surgery, the pathological tumor sizes were observed to be T1 in 13 patients, T2 in 14, T3 in 50 patients, and you can see the chart as well of the both T size comparison, and it was T4 in 5 patients, the pathological tumor size. The mean operative time was 340 minutes approximately. Other than that, mean blood loss was 100 milliliter almost. Surprisingly, there was no mortality in 90 days, and the mean post-operative hospital stay was almost 7 days. Uh, Other than that, the pathological circumferential resection margins were negative in 65 number of patients, and it was positive in 17 patients. The tumor perforation was observed in only 8 patients, while recurrence were observed overall in 34 cases. It was local in 22, distant in 27, or if we say combined recurrence, that was in 17 number of cases. Only one patient experienced perineal hernia clinically, that was observed clinically, and there were many other variables which we observed during our study, but because of the lack of the time for the abstract presentation, I have included only the important results here. I hope I have ended it in the time. So concluding my study, saying that laparoscopic procedures makes the anatomical landmark for levator transection in the pelvic cavity easy and clear for dissection. Extra levator abdominoperineal excision has evolved as safe procedure for locally advanced low rectal cancers. Thank you so much.
Nice presentation, Dr. Nigat. I have a question. How do you define low rectal tumor? Like, what is your landmark for that? Is it in centimeters or is it surgeon dependent?
Like if you are asking for extra elevator surgery, I have explained it in the first slide that there are some specific indication for that. And
No, sorry. What is your definition of low rectal tumor? Like, how
the,
far from the inner verge you define them as low rectal?
it's it's in centimeter actually. It depends actually which procedure we are going to perform. So it's
Well, I think that Nigat is probably closer to her answer. Usually, I believe the literature defines low lecture as 5 centimeter from
oh
the
yes,
inner
yes.
verge. I think that's what Dr. Mohsen Farid was probably pointing to.
Oh,
But
I'm not.
it's an interesting study you're presenting. Do you have
Thank
any
you
other
so much.
questions, Mohsen?
No, thank you.
So I have a question. So with this procedure, have you looked at the genitourinary dysfunction? Because
Yes,
with all these, especially with the high-low trial, there was a
yes,
significant.
we have observed a lot of other complications as well. I have the results in my hand actually, and the sexual dysfunction was observed in 17 number of patients. I haven't explained it in the presentation because of the lack of time, but we have observed many variables other than those which I have presented.
All right. Thank you very much, Nigat, for this thought-provoking work you're doing. We're gonna move on to our next presenter now. Um, Before I move on to my next presenter, who is from our local city fellow, Dr. Ghazanfar Ali. Ghazanfar is from the Great King Edward Medical University. He's a fellow there. Uh, And I want to take this opportunity to thank all these individuals who are working out in the community, especially in the government hospitals. I can imagine the kind of work you're doing and the kind of stress you have to bear with all those limited resources and patient load. And hats off to you guys that, you guys work in tough situation, tough conditions, and you've been thriving. And I believe when you present this work on this kind of platform, that tells us that yes, you guys are doing something noticeable, something remarkable. Thank you very much for coming in and presenting your work. I hand off the mic to Gazanfar, who is presenting on the risk factors, management, and outcome of colorectal tumors, presenting as emergency retrospective study. Over to you, Gazanfar.
Okay, thank you so much, Dr. Rehan. Can you see my screen?
Yes, we can hear you loud and clear. Please go on.
Okay. Okay. So my presentation topic today is risk factor management and outcome of colorectal tumors, presenting emergency cases at single institute. It's a retrospective study. First of all, I want to ask the participants a little question that why I choose blue color for this presentation. Can any attendants from the audience please choose the blue, dark blue color for that presentation? I hope everyone knows that the dark blue color is the color of the colorectal tumor. And the next one, the blue ribbon is the sign of colorectal cancer, and the March is the month of colorectal cancer awareness month. And there are other ribbons that are all related to other cancers. So the study is that approximately 15 to 30% of colorectal cancer patients present in emergencies, most common as obstruction and or perforation. And it carries poorer outcome for patients who undergo emergency surgery as compared with the elective surgery. The trend in colorectal cancer presentation has been changed over the last few years. And you can see the darker blue colors are the having more incidence, and the lighter blue color have the lesser incidence. And the below one, the mortalities, the darker ones, dark red color have more mortality as compared to the lower one, the pink ones. So these are the approximation global stats 2018
Sorry, Dr.
that
Gazanfar, can you
estimates
speak a
that.
little bit louder?
Okay, okay. So colorectal cancer is one of the most cancer presented annually, and third most common in men, second most common cancer among women, and world's second most common cause of death. So emergency presentation is increasing. The rise in cancer presentation at younger age in Asian population. That is study conducted by Chinese, and it's presented in Asian American Journal of Gastroenterology, having more presentation in emergency presentations. So clinical presentation in emergency is different from those in OPD. Patient present to emergency department with a condition of intestinal obstruction, bowel perforation, peritonitis, and it carries a bad prognosis. Ear presentation carries a bad prognosis because patients are usually malnutritioned, they are dehydrated, and usually present in older age, and these all carry a poor outcome. And these are also associated with the high cost of complication and mortality rates associated with emergency presentation. And so objective of our study, coming to our study, that we want to determine the risk factors, management, and outcome of colorectal cancer presenting at emergency department of New Hospital, Lahore. It was an observational study conducted in West Surgical Ward, and duration from 1st August to 31st September. 31st July, and including criteria was ager patient were more than 13 years and operated within 24 hours of presentation. Patient with obstructive signs and symptoms of perforation and bleeding, and having absent bowel sounds, and those with subsequent peritonitis. And those patients were excluded that the tumors completely obstructing the lumen or having positive bowel sounds and iatrogenic perforation due to colonic biopsies during colonoscopies, and all redo surgeries there are excluded from our study. So mean age of presentation in our study, quite a younger ones were having a mean age of presentation at 38 plus minus 17 standard deviation was mean age of presentation in our study. And the mean age of patients who survived were 35, and mean age of patients who died were 52 years. And these are the multiple factors. The males were 23, 57%, females were 7, 42%, and the family history of cancer was only positive in 9 patients, and they was not having family history of in 31 patients. So 78% roundabout patients that gave history of family history of cancer, and those presented in emergency. These are ASA scoring. Usually, patient presented with ASA 2 and 3 and 1. No patient presented with 4 or 5. And these are comorbid conditions. Patients usually had diabetes, little ones, or ischemic heart disease, but 15 patients or 38% percent of the patient doesn't give history of any comorbid conditions. And now this is the important one, that only 2 patients had previous history of colonoscopy or screening in their lifetime, and 38 patients or 95% of the patients presenting in the government hospital doesn't give history of any previous history of colonoscopy. And surgical indication for admission were intestinal obstruction was the major one. And the interesting one that slides is also that most patients presenting in emergencies was having ascending colon tumors. Usually it's said that rectosigmoid tumor is most common, but in the emergency presentation, you can see ascending colon in wall fracture was the most common site of the presentation. So the procedure, usually we did the right hemicolectomy, ileocolostomy. Majority had it stoma formation, and about 80% of the patient had stoma formation, and only 8% of the patients had 20% of the patient had anastomosis because of the poor conditions, poor comorbid conditions of the patient. A patient post of medical complication, 60% hadn't heavy developed complication, 10% had and surgical complication, around about 22% of the patient developed wound infection in their post-op. So the most common histopathology was adenocarcinoma. Again, it's right side of the patient, adenocarcinoma, and histological grade varied according to patients. So these are a few specimens I want to show. This is a tumor of cecum, ascending colon. We are the post, and this is an ascending colon mass. This is a hepatic flexure mass. We did hemicolectomy for that, and this is a transverse colon mass. These are all emergency surgeries we did in last 2 years. Sigmoid colon tumor again, and this is a recent one. I think it's this patient, quite a younger one, presented in last month, and that had a perforation due to rectal cancer. So again, the site-wise and right-sided tumors are most common than left-sided tumors. So picking points from our studies was that, again, I said earlier that in our study, in the emergency presentation, ascending colon tumor were contributed around about 50% of the cases that we dealt in last 2 years in emergencies. And again, the age again, it's said that our patient usually had around 50 years of age, but in our study, younger patients are coming in emergencies, and our patients were 38 years. Again, intestinal obstruction, again, it's the commonest cause and just a sign of presentation. Management depend upon the location and general operating condition. So Bira et al. In their research suggested that most common treatment was a resection and primary anastomosis. Unfortunately, in government setups, we dealing the patients with poor comorbid conditions, those who have malnutrition. So we didn't take the risk of performing resection and end-to-end anastomosis. We did resection and end-to-end in 20%, but we skipped that and made stoma in 80% of the patients. Again, that we our again studies showed that we studied 23% of the patient got infected and had wound infection after emergency surgeries, and antibiotic prophylaxis can reduce it from 35 to 20%. So again, the poor thing is that increased rate of post-operative complication leads to prolonged hospital stay of patient. So you can see in terms of hospitalization in terms of 15 days. So this patient really consume a lot of resources, a lot of bed strength of the hospital. And mortality was likely to die within 30 days. Right-sided colons are associated with high post-op mortality as compared So NHS introduced screening guidelines in 2006 with the main objective of early tumor presentation, detection, and reduction for emergency admissions. In our study, now the bad thing is that in our study that 95% of the patient didn't give history of any screening colonoscopy in their lifetime. So this is the how serious the problem is in our society. And these are the after our surgery, emergency surgery, 87% of the patients survived and 30% was mortality. So conclusion, colorectal tumors will continue to present in emergencies with varied mode of presentation. In our population, male gender, younger age, and ascending colon site has an increased risk of colon emergency presentation. And most patients had stoma formation at an emergency presentation. So the bad outcome was the patient who was presenting with bad ASA scores, and those patients who didn't have an colonoscopic screenings, and those patients who had post-op medical complication had bad prognosis. So this was a limitation of our study that it was a single institute research and the lack of long-term follow-up. We do follow up in our government setups as much we can do, but although we have a limited resources, so it's around about 2 years we are following that cases. Up till now, only few patients have presented with a recurrence. So this must be a recommendation that there must be public awareness campaigns about screening in high-risk patients. Screening facilities in public sector hospitals need to be increased. Reducing emergency presentation would enable health services to be used effectively and accurately, enhancing patient care, experiencing and increasing survival for patients with cancer. So this is again we discussed in last Surgicon, the national surgical conference that happened in last month. There is a need of national guidelines for screening of our population. We do believe in international guidelines,
Two
the
more
Western
minutes,
guidelines.
Gazanfar.
Thank you. So I beat the disease. There's a famous quote we can to say that Ronald Reagan was the 40th president, lived in a poor childhood to become a Hollywood film star, then claimed the Oval Office. Early in his second term, doctors found a growth in his large intestine. They removed the polyp and nearly 2 feet of intestine. The president's public experience helped to raise awareness about this type of cancer. He beat the disease, but Alzheimer's claimed his age at 93 years of age. Thank you. Thank you so much. Take home message is that once colon cancer becomes symptomatic, 9 times out of 10, it is too late. Thank you. Thank you so much.
Thank you very much for your
Any question?
presentation, Gazanfar. I have a couple questions before we move on to those questions. This is, I think, the most important message from your presentation is colon screening, screening, screening. And recently, the American Association has decreased the screening guideline age to 45, which actually was 50 for non-Black Americans. Now it's 45, which is actually the same age as of African Americans at 45. This is the most important message out of this talk. But before I move on, my first question is, your perioperative mortality was about 13%, 12.5%. And recently,
Yeah.
in 2019, French National Surgical Association put out a study on emergency surgeries on elderly patients, and their mortality was about overall mortality was 8.5%. But when you stratify the mortality for elderly with comorbid conditions, the mortality was about 10.5%. Mind that for youth, the
Yeah.
mortality was about 4.5%. So we are looking at a very young
Yeah.
population demographics. So what do you see? Where are we missing in order to improve our perioperative mortality? Because 12.5% versus 4.5% is a big difference.
Yeah, I want to share that the main thing is that the care of ICU care, the post of ICU care in government hospital, it's usually good, but few patients we need ventilator post-op, but it's usually vents are bound because limited resources of ventilators. These are not circumstances in Western population. Unfortunately, in our population, they usually need post-op ventilation after prolonged surgeries. But we do have a limited resource, limited setups. We can do what we can, but in the end, we can improve our ICU care in the post-op. I think I want to answer that. And the main thing is the ICU care, and because this is an extensive surgeries and a large resection, and we need ICU care post-op.
Okay. So summarizing, Gazanfar is claiming ICU care is probably the decisive factor in improving the perioperative mortality. Dr. Mohsen Farid, do you have any
Yeah.
questions?
Yes, I have a question for you, presenter. It was a very nice talk, very well organized actually. Do you have a data on divergent colostomy for these patients?
Yeah, I shared in my, let me share again. I shared a little bit in emergencies. Let me, so you can see the fourth one, a diversion loop lost means. We usually made the, in the rectal
Okay.
cancer, we do the, because it's an emergency cases, we have to get the emergency cases patient, don't take patient life at the cost of operation. So if we do perform 10 cases, that 25% of the patient, we did do colostomies in that.
Okay. And how did these patients do afterwards?
We usually that patient survive because of the shorter procedure, shorter emergency procedures. We do a loop colostomy, then we again the restage the cancer, restage the disease. We involve the oncologist who downstage the disease, radiotherapist, and then we again the plan the final surgery after that.
Okay. Thank
Thank
you.
you very much, folks. We are tight on the timeline. Thank you very much, Gazanfar, for
Thank you. Thank you so much.
coming in and presenting your work. Thank you. We're going to move on to our next presenter.
Thank you.
Um, our next presenter is our uh, Year 4 resident of surgical oncology, Dr. Osama Shakil. He's a very good cricketer also. Um Before I move on to Osama, uh, I know you're a bit nervous today. I don't want you to be nervous. I know you can do it. And you're presenting a
Thank
lot
you.
of work today. So, they say medicine is like wisdom. That is not a product of schooling, but it's a lifetime or lifelong pursuit. We keep on learning everything every day. You're presenting a very rare thing, which is a very rare type of pathology. So I'm going to hand over to you. So Osama is presenting us I'm sorry. Osama is presenting us extrapulmonary gastrointestinal small cell carcinoma. Over to you, Osama. Thank you.
Thank you very much, sir. Can you see my presentation, sir?
Yes.
Thank you. Good morning, everyone. Thank you for giving me the opportunity to share my presentation with you guys. Today, my topic of presentation is extrapulmonary gastrointestinal small cell carcinoma. It is a single institute experience from Shaukat Khanum Hospital of 14 patients. My name is Dr. Osama Shakil. I'm a general surgery resident year 4 at Shaukat Khanum Hospital. So first of all, extrapulmonary small cell carcinoma is a very rare disease with aggressive nature. It was first described by DeGrade and Kennedy in 1930. It was formerly called, before the 1990s, it was called oat cell carcinoma or extrapulmonary oat cell carcinoma. But after that, extrapulmonary small cell carcinoma term was coined. So the extrapulmonary small cell carcinoma can affect many different locations of the body, including trachea, larynx, salivary glands, and organ of GI tract. The involvement of extrapulmonary site is about 2.5%, and they say that the cells which are the causative factor for the extrapulmonary cell carcinoma are the neuroendocrine cells. So the rationale of our study is to discuss about the clinic pathological factors, the diagnostic measures, and the prognosis of the disease. The study was conducted at Shaukat Khanum Hospital. The duration of the study was about 23 years, and it is a retrospective study with descriptive and convenience sampling. The study method, the data was collected from the Human Information System of Shaukat Khanum Hospital, and the analysis was performed on the SPSS 20. So, uh, what we do for the collection of the patient, the only thing is that we have to check whether the small cell carcinoma, the lung is involved or not. That we perform the CT scan of the chest to see the involvement of the lung by small cell carcinoma. If there is no involvement, then we say that it is a primary disease of the extrapulmonary site. From the results point of view, most of our patients are females, constituting about 64.3% of the patients. Um, Almost all of the patients are above 50 years of age, with a median age of 59 years. Among the patients who are having who had esophageal carcinoma, small cell carcinoma, dysphagia was the most common cancer, and the median duration of the symptoms before the presentation of symptoms till the diagnosis was 53.42 age. After the presentation of symptoms, the median age at our from our study was 53.42 age. The most common site was the esophagus, followed by gallbladder, rectum, stomach, gastroesophageal junction, and pancreas. Most of the patients with the esophagus cancer, as I told you, came to us with the history of dysphagia. The patient with gallbladder carcinoma, they had metastasis at the time of the presentation. Uh, the diagnosis of small cell carcinoma is based on the histopathological, it's a histopathological diagnosis. Four types of immunohistochemical markers are used for the diagnosis of small cell carcinoma, named them CD56, synaptobevin, chromogramin, and cytokeratin. In our study, it showed that the 71.4% of the patient had cytokeratin positive disease. Uh, 35.7% of the patient had chromogranin positive disease, and only 14.3 had synaptobevin, and 35.6% had CD56 positive disease. The treatment modality. As we all know from the small cell carcinoma from the lung part, that it's a systemic disease. So most of the time, the treatment comprises of the systemic therapy, which includes chemotherapy and the radiotherapy. Most of the time, it is a chemotherapy. The patient who had metastasis at the time of presentation, they underwent palliation or palliative chemotherapy. One of the patient had surgery because he had pancreatic small cell carcinoma. For that, a Whipple procedure was performed. From metastasis point of view, liver is the most common site of metastasis, and smoking is a risk factor for metastasis. The conclusion is extrapulmonary small cell carcinoma. It is a rare malignancy. The age ranges from 20 to 78 years. Immunohistochemical markers play an essential role in the histopathological diagnosis of extrapulmonary small cell carcinoma. It is a neoplasm of aggressive nature. Extensive disease was seen in 57.1% of the patient. When I say the extensive disease, it means a locally advanced disease. Or the second thing, the disease has metastasis at the time of presentation or after the treatment, completion of treatment. Yes, again, multimodality treatment is the current standard of treatment. For chemotherapy, most of the times, cisplatin and etoposide was the commonest regime used, which was followed by carboplatin or etoposide. Local recurrence was observed in 3 patients, which makes up 21.4% of the patients. The metastasis was common among 14 patients, which was seen in 35.7% of the patients. The median overall survival in this case series was 15 months. In our case series, 2 patients were alive. 5 were dead because of the disease, either metastasis or local recurrence. Unfortunately, because the study period is 23 years, 7% patients were lost to follow-up, which makes up about 50% of the total number of patients. This is the limitation, although it is a retrospective disease and there are multiple patients which are lost to follow-up. But the good point about my study is that what we did is it is the first of its kind from Pakistan. Nobody has worked on it, and this study will give, although this study cannot be used as a reference point for the guideline management for the management or making the guidelines, but it can be used as a reference point for future studies to understand the disease by the professionals who treat the disease, as it is a rare disease. And apart from that, a randomized controlled trial and multi-center studies are required for better understanding of the disease and response to the treatment modalities. Thank you very much. And I want to thank my consultants, Dr. Shahid Khattak and Dr. Amir Ali Sayed, for helping out uh, in doing this research project. Thank you.
Thank you very much, Osama, for presenting your work. Um, this is an aggressive pathology,
Yeah,
and and unfortunately a very dismal 5-year survival rate. Some studies quote that for limited disease, the survival is about 5-year survival is about. I mean, actually, the median survival is about 1.5 to 3.5 years.
yeah,
Even with extensive disease, the survival is not more than a year.
yeah. It
So
is
with aggressive therapy, do you see a survival benefit? And if not, what do you suggest we should start thinking in order to at least uh, bring some more longevity in these patients?
so. Unfortunately, again, because it is a rare disease and we don't see that many patients, so we have not concluded what is required for this patient. What we do for these patients, we take out from the studies what when we treat small cell carcinoma of lungs. Yes, the disease should be treated with aggressive therapies, including multimodality treatment, likely chemotherapy and radiotherapy. But unfortunately, because of the rarity of the disease, we have not come to the point what is required for this patient. There are some studies which say that go for all, but unfortunately there is the scarcity in the data from
Okay,
any part of
sure,
the world.
sure. I can totally understand the scarcity of data is there. The other thing I noted that, the loss of follow-up.
Yeah,
Obviously, that is a bigger factor in assessing your median survival. If it's really the actual survival, which is 15 months, you pointed out in your study.
yeah.
Um, I'm going to ask Dr. Mohsin Fareed if he has any questions for Osama.
Yeah, Osama, it's a very nice presentation on a very rare topic, and I can understand the difficulties that one can encounter while getting such a data. So it is a remarkable work. My only question is, did any of these patients get PET scan, or is there any role of PET scan in their diagnosis and rule out other sites of disease?
Well, most of the times the patients when they presented to us, because it is the duration of the study is 23 years, so PET scan was not available like 5 to 7 years or 10 years back, so we don't know about that. But the patient who presented to us in the last 5 or 6 years, in the staging workup, we mostly perform the CT scan for the staging workup. But if they develop some metastasis or something like that, then we can easily perform a PET scan to see if there any other metastasis or a disease somewhere else.
Okay,
Thank
thank
you
you.
very much,
Thank you
Osama.
very
Thank you,
much.
Dr.
Thank you.
Mohsin. Uh, Over to our next presenter. Uh, I was looking at the topic for the next presenter, and I was carried away with this thought that comes December 2019, we start hearing about a disease, and then January, a little bit more from WHO, and comes February, and there's chaos. March, lockdown across the globe, deaths. And now that we have known, I mean, we have understood a bit about that disease and working on the vaccination development and controlling the disease from, primary prevention standpoint, we've been facing a daunting challenge, a daunting task to overcome this disease. Unfortunately, when we encounter these kinds of pandemics, that tells us that nature controls everything. So here we have our fellow from surgical oncology, Abdur Rahman. Thank you very much for joining us. And he's going to be talking about this very topic related to our field of work, outcomes of surgeries performed during COVID-19 pandemic at a dedicated cancer hospital. Over to you, Abdur Rahman.
Thank you, sir. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. My name is Dr. Abdur Rahman, and today my talk is regarding outcomes of surgical operations that were performed here at our center at Shaukat Khanum Memorial Cancer Hospital during the pandemic. So the COVID-19 pandemic, as we already know, it is one of the most difficult times that we have faced until now. And starting from China. This virus quickly found its way across the boundaries, across the international borders, and it had affected more than 200 countries all over the world. So the first case of COVID-19 was reported on 26 February 2020 in Pakistan. In the beginning, the course of this virus was not known to most of the people. It was basically uh, the the virus had an aerosol transmission that caused it that had that co- it was very difficult to predict the behavior of this novel virus. So here are some of the statistics from the government of Pakistan portal. These are the statistics that show that almost 338,000 cases have been reported till now, and there have been almost 7,000 deaths during this period. As we can see in the graph below, that the number of the cases has steadily increased from April to May, and it rose to the maximum in the June, after which the number of the cases have steadily decreased. So what basically how this COVID-19 has impact on our lives, as we can see that the streets that were once inhabited were deserted. There was a deafening silence that could be heard from a mile away, and the streets that were once full of life all came to a halt. So how this pandemic affected our healthcare? Now I'm going to talk about that. So the surgical activities all over the globe were limited, and the surgical service came to a halt, mainly because we did not know, and most of the healthcare system was focused on preventing this contagion and to limit its spread. So the surgical service was basically stopped in the best interest of the patient as well as the healthcare professionals. So the oncology cases deferral led to a negative impact on the survival of the patients because they could not be deferred for a longer period of time. Many guidelines emerged on how to effectively deal with this pandemic from the Royal College of Surgeons in England and the American College of Surgeons of America. However, since we have a very large patient load, and not only the patients we have are from Pakistan, but we have a catchment area as far as from Afghanistan. So refusing treatment to all of these patients, it was easier said than done. So we basically needed a policy, an effective policy, to have a clear roadmap on how to tackle this situation without compromising clinical care. So the Department of Infectious Diseases formulated a policy keeping in view the available evidences. And the policy that we had was that all patients were required to undergo a COVID PCR 48 hours before surgery. The positive patients were advised home quarantine for 14 days, and surgery was inadvertently delayed for 2 weeks. After 2 weeks, these patients were reassessed, and surgery was undertaken only if the patient was symptom-free. In emergent cases, preoperative PCR was sent before the surgery. And for only the emergent cases, the surgery was proceeded and the patient was labeled as COVID positive until it was proven otherwise and until the report was available. In addition to all these hospital policies, such as wearing a mask and observing social distancing was deemed mandatory. Provision of PPEs during surgery was also ensured, and strict hand hygiene and barrier methods were used during surgery. So the positive patients were kept in a dedicated COVID facility that included a COVID ICU and a COVID isolation facility. So here is the picture of the Camp COVID that was started to basically screen these patients. That all the patients that came to us, these were screened in this Camp COVID because the Shaukat hospital is the one of the labs, one of the hospitals that was credited with the task of performing COVID tests all over Pakistan. So the Khanum hospital was basically fighting on two fronts: cancer as well as on the coronavirus as well. So my study design is basically a retrospective study, and the data was collected from hospital information system, and SPSS-20 was used for data analysis. So all the cases that were performed from 1st of the March to July to 31st of July 2020 were included in this study. The cases that were performed in the specialty of GI, hepatobiliary, gynae-oncology, urology, neurosurgery, orthopedics, plastics, and head and neck cancers were included. The cases were performed as an emergency or an elective procedure. These cases were performed under general anesthesia, and all the cases that were, were performed under local anesthesia were excluded from the study. So coming to the results. So during this time period, 1,863 elective cases and 279 emergent cases were done. And out of all these patients, this, according to my study criteria, a total of 1,105 patients were included in my study. So here is the specialty-wise distribution of the cases that were done. We can see that the most number of the cases were done in the specialty of urology, followed by GI and then head and neck. All of the other specialties also operated upon patients, and this is the data that is solely of the oncological patients, the oncological procedures that were done. So 928 patients were operated upon electively, while 177 patients were operated on emergent basis. 68% of my patients were male and 32% were female. So coming to the results, there is a set of population in my study that in whom the COVID test was not done. Because the hospital policy was implemented in the first week of March, because the surgical procedures remained suspended for the period of 2 weeks at the end of March and to the beginning of April. The patients that were operated during this time period did not had their COVID done because it was not the hospital policy. However, after the implementation of the hospital policy, out of all the patients who underwent COVID testing, 100 patients tested positive. So what became of these 100 patients? We are more interested in the results of these patients and the outcome of these patients because they were at an increased risk of post-operative respiratory complications. And out of these cases, of 100 cases, 92 patients were diagnosed preoperatively, and they observed a home quarantine for 2 weeks, and they were called back for surgery after 2 weeks to be operated upon. And 8 patients were those patients who presented for emergency procedures, and they tested positive. So what were the outcomes of these 100 positive patients? Among them, those that tested positive in the elective setting, and they basically observed 2 weeks of quarantine. Out of these, 2 patients developed post-operative COVID symptoms, and they were admitted to the COVID ICU facility. And unfortunately, these 2 patients died. However, in the emergency cases, all of the 8 patients out of 177 cases who were who presented in the emergency, 8 patients were tested positive. They were all of them were admitted in COVID facility, and only 1 patient died. So here I have shown that 10 patients were admitted. A total of 10 patients were admitted in the COVID facility, that is in isolation and ICU as well. Out of these 10 patients, 3 patients died who were in the COVID ICU, while 7 patients remained in isolation and were discharged after their treatment. So looking on the international data, there are very limited studies who have such a large number of patients, so all of these studies that I have looked into, the COVID-19 implications, reactions, and future directions, basically all these studies have shown that surgery can be done, but after following certain precautions and after proper preparation, pre-operative preparation. So one of the debates during this pandemic was whether to use a laparoscopy in the patients or not, because it was basically seen that that the surgical smoke and the use of the gas propagated the spread of this virus. So in our study, a total of 219 patients were operated using a laparoscope. I have not included the patients who underwent endoscopic procedures like cystoscopies in this data. So these are the solely patients who underwent laparoscopic procedures, and out of these laparoscopic procedures, 235 procedures were completed using a laparoscope. These included total laparoscopic and lab-assisted procedures.
One more
While
minute, Abdurrahman. I'm sorry. One more minute.
Yes. So out of these patients, only one patient developed post-operative COVID-related respiratory failure in diet. So what we can conclude from this study is that oncological patients can be safely operated in COVID pandemic with adequate preparation and safety measures. Laparoscopy can be employed safely because our data suggests that the there is no added morbidity and mortality in using the laparoscope, both for the doctors as well as for the patient. And a vigorous scheme for personal protection and hand hygiene must be instituted to mitigate the transmission of the virus. Uh, and in the end, I would like to say that the Khanum Hospital has always been there for the patient care, and it is indeed a hospital that has been founded by the people, for the people, and of the people. And in the end, I would like to acknowledge my team and Dr. Toki, Dr. Hamza, Dr. Wada Beg, Dr. Fahad Shah, and my supervisors, Dr. Shahid Khadak and Anil. Thank you.
Thank you very much. We are on a tight timeline, Abdurrahman. I'm going to ask Dr. Mohsen Farid if he has any questions. Otherwise, we'll move on to our next presenter.
I think we can proceed to next presenter.
Right. Thank you very much, Mohsen. This is a remarkable work we are doing here at Shaukat Khanum, and I'm so proud of being a member of this awesome team here at Shaukat Khanum that has been at the forefront of COVID-19 pandemic, serving the community and also serving our cancer patients as well. It was definitely challenging when we were facing the peak of this infection. Obviously, this is another task at this point we are facing, especially with the second wave. Now we are welcoming our presenter Osama Shakil one more time in a more confident mood he looks into. They say you don't understand anything until you learn it more than one way. So, being surgeons, we try to learn things in so many different ways, so many different approaches. So here we have Osama, who's going to be talking about laparoscopic curative resection for right-sided colonic tumors, his initial experience with his team. Over to you, Osama. Thank you.
Thank you very much again, sir. So my topic of presentation, the second topic of presentation is the laparoscopic assisted surgery for the right-sided colonic cancer. Again, I'm Dr. Osama Shakil. First of all of the patients who come to the Shaukat Khanum Hospital, we have a policy made. They have to go through the extensive workup for staging of the disease. Then the patient will be discussed in MDT as soon as possible. Professor Bill Heel first introduced the concept of total mesorectal excision in 1980s. The concept is to do the surgery through embryological plane, which has resulted in the 5-year survival outcome which was reduced before them 45% to 75%. Just a minute, sir. I think there's some issue with the screen sharing.
All right, now we can see your screen.
Yeah,
thank you.
I'm so sorry for that. So the total mesorectal excision was first performed by Professor Bill Heel in 1980s. The concept behind the total mesorectal excision was to perform surgery through the embryological plane, which has resulted in the better 5-year survival outcomes to 75% and the reduction of the local recurrence rate. After 10 to 20 years, then the concept of complete mesocolic excision, arises. The concept was same to perform the surgery through embryological planes. It was first introduced by Hohenberger. Although there are some lag because the concept is not followed completely as TME, but the trends are changing now. The definition of CME is to remove all of the colon along with the lymphovascular supply by resecting the colon and the mesocolon in an intact visceral envelope, which holds the potentially involved lymph nodes. And the second component of this complete mesocolic excision is central vascular ligation. It is a central vascular tie so that all of the lymph nodes involved or uninvolved removed with the package to reduce the local recurrence rate. It is a retrospective study with convenient sampling. The data is of 12 years from January 2010 to August 2018. All of the patients who underwent laparoscopic right-sided colonic cancer were included in the study. The data is retrieved from the Human Information System of Shaukat Khanum Hospital, and the ethical approval was sought from the Institutional Review Board of the Shaukat Khanum Hospital. The results. We retrieved the data of 75 patients. The male to female ratio was 2.94 to 1. Median age at the diagnosis of the right-sided colonic cancer was 52 years, but the range is from 21, which is an early age, and the elderly patient, which were 82 years of age. Most of the times, the most common affected site of the right side colonic cancer was ascending colon, which was 31.8%. It was followed by hepatic flexure, cecum, then transverse colon, and the least common site was the appendix. 72% under patients underwent elective surgery. Only 3 patients underwent emergency surgery. This is the trend, the change of trend from open procedure to the laparoscopic procedure at Shaukat Khanum Hospital. As you can see, from 2005 to 2010, we were performing more right hemicolectomies via open method. But during 2011 to 2015, we were in the same ratio because the learning curve has gone towards the laparoscopic side. We were in the same ratio for laparoscopy with the open method. And when during the years between 2016 and 2018, more of the patients underwent laparoscopic procedures, some laparoscopic assisted procedures, and the conversion rate was 68%. So this is the trend shifting. Uh, right hemicolectomy is performed approximately in 70% of the patient, although the 31% of the patients underwent extended right hemicolectomy. The median duration of surgery after the laparoscopic procedure was 5 days. We have 3 to 13 is the range, which is quite low. As we saw the data of the previous my colleague from King Edward Medical College. Out of 75 patients, 6 patients had complications. They were not the major complications. The 4 patients developed superficial surgical site infection, and 2 patients developed intra-abdominal collection, for which a radiological intra-abdominal drain was placed for the management of the patient, and they all went home. This is some of the operative findings from surgical and survival outcomes from the right hemicolectomy, laparoscopic. The mean operative time for the laparoscopic right hemicolectomy was the 95 minutes, approximately 3.5 hours. Median blood loss was very low, which is 50 mL. The adequate proximal and distal margins were achieved. As you can see, the mean proximal margin was 12 centimeter, and the distal margin was 10 centimeter. The pathological key stage showed that most of the procedures we performed at Shaukat Khanum Hospital were for advanced diseases, T3 or T4. And as per the guidelines of American Association of Pathology, at least 12 lymph nodes should be removed for the correct staging or lymph node staging of the disease. And you can see from our study that the median lymph node we extracted out from the patient were 20, and the median involvement of the lymph node was 1.14. Good for us that there is neither in 30-day or in 90-day, there is no mortality. The recurrence was observed in 4 patients, which is quite low because of the CME, complete mesenchymal excision, and metastasis was observed in 9 patients out of 75. This is the Kaplan-Meier of a disease-free survival and overall survival, showing that from our perspective, this is a 3-year disease-free survival, which showed that over 80% of the patient they have now, because we are still following the patient, they have disease-free survival, which is quite good for right-sided colonic cancer. And if we see that the overall survival is just close to 80%, which is again very good for the patient with right-sided colonic cancer. We conclude that laparoscopic right-sided colonic resection is associated with reduction in hospital stay, reasonable operative outcomes, and acceptable morbidity. Laparoscopic resection is an acceptable alternative to open surgery in both surgical and survival outcomes. This is just an initial experience from Shaukat Khanum Hospital. We'll perform some researches to compare the laparoscopic and open outcomes of among our patients. And apart from that, we are aiming for perform a long-term survival outcome study from this institute. This is from me. Thank you very much for listening to me.
Thank you very much, Osama. I belong to the same clan of minimally invasive surgeons, and I appreciate the effort of moving from an open surgical technique to a minimally invasive technique, whether that's conventional laparoscopy or robotic technique. So, have you looked at the data regarding the most important stuff with conversion versus laparoscopy regarding tolerance of diet, accelerated return of bowel functions, analgesic and requirements, and hospital stay? Obviously, I saw hospital stay, which is obviously meaningful. Have you looked at the other factors too?
So yes, so this is an initial experience from our study. We are conducting some studies to see what is the short-term outcomes like the return of the bowel and the pain outcome. So we are looking into this. We'll publish this in upcoming years.
Every time I looked at colorectal laparoscopic procedures when I visit your ORs, I see the finesse, I see the clean surgical techniques, and I'm really impressed with all those things. Hats off to your team. Thank you very much.
Thank you
Dr.
very much.
Mohsen Fareed, over to you if you have any questions.
Yeah, it's a very interesting topic, and I would love to see the long-term results actually
Yeah.
for this laparoscopic approach, because for some other like gynecological cancers, ovarian cancers, open approach is now considered favorable, and laparoscopic in the long term has not shown that promising results that was expected from it. So I think it will be very good to present and to collect this data and to present long-term oncological outcomes, especially disease-free survival and overall survival in these patients. That would be exciting, actually.
I just
Thank
want
you.
to make a point. I believe that Dr. Mohsen Fareed is probably pointing towards the cervical cancer data around regarding laparoscopic intervention, not the ovarian data. Cervical data definitely supports open procedures more so since 2018 when the landmark study from MD Anderson came out. But thank you very much, Osama, for giving us this enlightened information on surgical intervention. We are going to move on to our
Thank
next
you, sir.
presenter. Um, you know, surgery is not the only option in all the patients. Sometimes we have to move on to less invasive options. And when we move on to less invasive options, our medical colleagues are usually the ones who carry this feather in their hats. They are our eyes and ears, for the matter sake. Um, in helping us improving the quality of life of the patients and improving the outcomes of the patients. Our next presenter who's going to be coming in is is completing his fellowship in gastroenterology here at Shaukat Khanum, Dr. Saad Muhammad Saeed. Saad looks very young and handsome today. I saw him a few days ago, and with his not unshaved, face, he was looking a bit mature. So he's going to be talking about pyloric stent insertion and malignant gastric outlet obstruction, a scope beyond palliation. Very important topic, especially from our standpoint when we see a lot of gastrointestinal malignancies here at Shaukat Khanum. Over to you, Saad.
Thank you. Thank you so much for the nice comments, Dr. Han. And I'm Dr. Saad. As Dr. Han has already introduced me, I'm currently working as a fellow in gastroenterology at Shaukat Khanum Cancer Hospital and Research Center at Lahore. And today I'll be discussing pyloric stent insertion, malignant gastric outlet obstruction, moving beyond palliation. So it's kind of a long presentation. I'll just jump right into it. So as most of us would know, malignant gastric outlet obstruction occurs secondary to tumor in the distal stomach or the proximal duodenum, or by extrinsic compression, for example, a pancreatic head tumor, or by malignant nodal mass. Symptoms may include nausea, intractable vomiting, and abdominal pain. For many years, surgical gastrojejunostomy has been considered a standard palliative treatment for patients presenting with irresectable, locally advanced GI malignancies causing gastric outlet obstruction, whereas upfront gastrectomy was reserved for resectable gastric tumors. Whereas self-expandable metallic stents, or SEMS, are frequently used as for obstructing colonic tumors awaiting curative surgery, their role has not yet been established for similar upper GI malignancies. The importance of relieving obstruction in resectable obstructing tumors is not only just for symptom control, but has a considerable effect on the quality of life, and ensuring an uninterrupted neoadjuvant treatment, which is now a standard of care for upper GI malignancies, including gastric carcinoma, and this has been shown to improve survival. To the best of our knowledge, this is the largest study of patients with obstructing resectable gastric tumors where SEMS insertion was employed as a bridge to surgery. So the aim of the study was to evaluate efficacy and safety of pyloric stents in gastric outlet obstruction caused by gastric cancers, and also to evaluate 1-year survival in patients undergoing curative surgery where the disease was resectable. So how did we actually do it? After the IRB approved Institutional Review Board approval from Shaukat Khanum Hospital, Lahore, we did a retrospective review of 161 patients undergoing placement of SEMS for gastric outlet obstruction due to gastric cancer. The data was evaluated from for a period of 5 years, from 2014 to 2019. So the inclusion criteria included all gastric cancers presenting with gastric outlet obstruction at initial presentation, and the patients 18 to 80 years of age were included. Exclusion criteria comprised of gastric outlet obstruction secondary to cancers other than gastric cancers, and gastric carcinomas other than adenocarcinomas. Patients with a history of prior stent insertion were also excluded from the study. So the stent efficacy was measured in terms of gastric outlet obstruction scoring system, or GOOS for convenience, at the time of stent insertion at 1 and 12 weeks. So the GOOS is basically a scale from 0 to 3, with 0 meaning the patient is absolutely dysphagic, while 3 means the patient has an ability to take regular diet. The safety was measured in terms of early and delayed stent-related complications occurring between 7 days and after 7 days, respectively. The postoperative complication and 1-year survival following the stent insertion was also calculated. The nutritional status was assessed in terms of BMI and the serum albumin at the time of insertion and at 4 weeks, which was basically the neoadjuvant treatment period. Kind of a busy slide regarding patient characteristics. Out of the 161 patients, 110 were males and 51 were females, with a mean age of 50.9 years. 83.8% had no comorbidities, while 7.4% had diabetes and hypertension. This was followed by other less frequently occurring comorbidities listed at the end of the screen. So the clinical success was measured in terms of GOOS and the improvement in GOOS. The GOOS was measured at the time of stent insertion, 1 and 12 weeks following stent insertion. As you can see that the GOOS at the time of stent insertion was 0.27, meaning essentially the patients were dysphagic at this point of time, while it improved to 1.8 and 2.1 at 7 days and 12 weeks respectively, meaning that the patients were at least taking semi-solids at this time. This was proven by the very statistically significant p-value. The maintenance of nutrition at the time of stent insertion at 4 weeks was measured by serum albumin, which remained relatively unchanged. And at the same time, the BMI was measured at the time of stent insertion and at 4 weeks. And as you can see that the weight was well maintained following stent insertion. The p-values over here are statistically insignificant, meaning that these changes were not really important at this time. So 1-year survival was calculated for the 35 patients who actually had resectable disease and underwent neoadjuvant chemo followed by curative surgery. The data was collected, and after excluding the 3 patients that lost to follow-up, the survival was calculated to be 87.5%. Of the 4 patients that had unfortunately died at 12 months, 1 of them died from a postoperative complication, and the other 3 dying from progressive metastatic disease. This is a Kaplan-Meier curve showing the 1-year survival for the patients with resectable disease. Fortunately, none of our patients experienced any life-threatening stent-related complications, including aspiration, pneumonia, and perforation, although 13% had stent fracture, 21.7% had stent migration, and 6.8% had stent obstruction. Along with that, 36.6% of our patients required restenting for any of the above-mentioned stent-related complications. So comparing to a similar study done at our own institute, the improvement of GauS to 0.2 to 3 by day 7 was 53.6% back then, and now it's close to 70% in this current study. A meta-analysis by Defriterios and colleagues suggests that maintenance of an adequate nutrition status by any means is of paramount importance to allow uninterrupted neoadjuvant chemotherapy. Similarly, Miyabi and colleagues also suggested that SEMS placement for malignant gastric outlet obstruction in patients undergoing chemotherapy helps in an uneventful course and an improvement in overall survival. So combining the conclusion of these 2 studies, as evident from our results, SEMS insertion helps in maintaining the nutritional status during the neoadjuvant period, which was evident by the unchanged albumin and serum albumin and the BMI. Luckily, there were no increased risk of postoperative complications following stent insertion. When comparing to the literature where the patient underwent curative surgery without prior stent insertion and the postoperative complication rate was 9.5%, only 1 of our patients experienced a postoperative anastomotic leak, making our complication rate to be 3.1%. A study by Yingbo Gong and colleagues suggested a 1-year survival of curative surgery following for gastric cancer to be 81.3%, while our studies suggested it to be 87.5%. So to sum it all up, in our experience, pyloric stent insertion leads to a relief of malignant gastric outlet obstruction, helps maintain nutritional status during neoadjuvant period, and this improves survival, and this is not associated with an increased risk of postoperative complications. Therefore, we suggest its use not only as a palliative measure, but also as a bridge to surgery for patients undergoing this procedure for obstructing resectable gastric tumors. Thank you.
The kind of stents you were using were uncovered stents, is that right? Or covered?
So we were using fully covered metallic stents. These are stents that are easily removed afterwards. So the reason of using these stents was because these patients were coming in with gastric outlet obstruction at the time of initial presentation. And at that time, they hadn't been completely worked up with the staging laparoscopy. And we didn't actually know that the disease was going to be treated with a curative versus a palliative intent. So we inserted fully covered metallic stent in all of these patients.
Well, they obviously your data doesn't have a lot of complications, especially the migration risk, which is significant with the covered stents usually. Is that right?
Yes, sir.
Okay. What difference in your technique is there that makes this a significant change that the other data, meaning data from the outside institution, supports that covered stents obviously they migrate quickly, right?
Exactly. Yes.
But they are more safer because they don't let tumor to ingrow. Is that right?
Yes, sir.
So
Yeah,
what is the specific thing you're doing differently from other people, other folks across the globe that makes you have less migratory risk?
Comparing to the literature, I don't think we had a lesser risk of stent migration. I mean, quite a lot of patients of our were experiencing stent-related migrations, and this was particularly due to the fact that these were covered stents, and secondly, that these patients were receiving neoadjuvant chemotherapy. So again, to the response of chemotherapy, the tumor was shrinking, and again, the stent were migrating. So that's why a lot of our patients did not require restenting for stent migration. because when we evaluated them for stent migration, they actually showed a shrinkage of tumor, and the lumen wasn't narrow enough to hold the stent. So I think that's something different that we're doing. We're giving them neoadjuvant chemotherapy, and that's shrinking the tumor, and that's allowing the stent to migrate, other than the fact that they're fully covered metallic stents.
Thank you. Thank you. Dr. Mohsen Fareed.
Yeah, Saad, it's really a nice study, and we
Thank you.
always think of stent migration, as Rehan has pointed out, because of treatment effect. Do you have any data of association between radiation treatment and stent migration?
No, sir, not right now. We'll, we'll have to look it up, but not right now, sir.
Okay, because this is one thing that we always have to consider, even with palliative radiation. If the stent is there, there is a increased risk of stent migration. So that would be something that you can always look in the future.
Okay, thank you, sir. We'll do that.
Thank you very much, Saad, for your presentation. We're going to move on to our last presenter. But I'm going to take this opportunity to thank again all the technical staff that has been pivotal in making this symposium very fluent, very it's working like a well-oiled machine, I should say. I thank to all the organizers who have worked hard day and night with their sweat and blood in this successful symposium. Thank you very much. Our next presenter is here. Before I go on to Sundas, she is also a fellow from gastroenterology. Thank you very much for joining us, Sundas. I was reading a quote today, and the quote goes like, "The purpose of life is not to be happy. It is to be useful, to be compassionate, to have it make some difference that you have lived and you have lived well." Thank you very much for making life easier for us, for us as a colleague, for us as surgeons. Sundas is going to be talking about safety and efficacy of esophageal stents for anastomotic strictures. Thank you very much. Sundas, over to you.
Thank you, Dr. Rehan. Good afternoon. I am Dr. Sundas. I am fellow in gastroenterology at Shaukat Khanum Hospital, Lahore. Today, I am going to present safety and efficacy of esophageal stents for esophageal and asthmatic strictures. It's a single center experience over 10 years. Starting with the introduction of benign and asthmatic stricture, it's a very well-known complication post-esophagectomy with an incidence reaching up to 30%. The non-surgical endoscopic bougie and balloon dilatation is considered as a first-line therapy, but usually repeated sessions are required and recurrences as high as up to 43%. The treatment of the recurrent and refractory strictures is even more complex. It's controversial, and there is no clear-cut guidelines over it. The other options for recurrent and refractory strictures are we can keep on doing repeated dilatation. Endoscopic incision with and without steroid injections can be done. We can place stents as well, like fully covered self-expandable metallic stents, biodegradable stents, or lumen-opposing metallic stents. Surgery can be used as a last resort, but usually it may end up with more anastomotic strictures, and there is high morbidity and mortality associated with surgeries. So repeated endoscopic sessions are additional physical and financial liability on patients. So early alternative methods like early stent insertion has been rightly investigated in a few studies. The main aim of our study was to evaluate the efficacy and safety of stent insertion in post-esophagectomy benign and asthmatic strictures. So after taking the approval from Institutional Review Board of Shaukat Khanum Hospital, a retrospective analysis was done. It was done on 28 patients who underwent esophageal stent placement for post-esophagectomy and asthmatic strictures. The data was collected for 10 years between January 2009 till January 2019. The inclusion criteria comprised of all the patients with age above 18 years. Both refractory and non-refractory strictures were taken. However, non-anastomotic benign strictures and histopathology-proven malignant strictures were excluded. So there are a few definitions that would be helpful in understanding of subsequent slides. So efficacy includes both technical and clinical success. The technical success is the deployment of stent through the stricture without any immediate complication, whereas clinical success is the improvement in patient symptoms assessed using the dysphagia score at 4 weeks, 12 weeks, and 1 year following stent placement. The dysphagia score is from 0 to 4. 0 means asymptomatic patient, whereas 4 means absolutely dysphagic patient. 2 is in between, means patient can have a semi-solid diet. So the safety is the complications following stent insertion. There could be serious complications associated with the stents like perforation, fistula formation, or aspiration pneumonia. Some minor complications could occur as well, like stent migration and stridor. The refractory anastomotic strictures are those who require 3 or more endoscopic interventions prior to stent insertion. These are the general characteristics of our patient in our study. We had total number of 28 patients, out of which 12 were males and 16 were females with an average age of 57 years. Out of them, 10.7% had comorbidities like diabetes and hypertension. Rest of them had none, whereas 92% of the patient had previous treatment for their original disease, that was chemotherapy or radiation, both. We also calculated the body mass index of the patient. 17% were underweight, 46% had normal weight, and 35% patient were overweight. The average time to develop dysphagia post-esophagectomy was 12.5 refractory stents. 3 different types of stents. 5 had biodegradable stents and 3 had lumen-opposing metallic stent. 20 had fully covered self-expandable metallic stents. So we calculated the clinical success by assessing the dysphagia score, calculating at 4 weeks, 12 weeks, and 1 year. When we compare it at baseline, initially we compared the dysphagia score of 4 weeks with baseline. When we had 28 patients, there was significant improvement in the patient symptoms. Similarly, at 12 weeks, when we had 26 patients, again, the patient has significant improvement in their symptoms, and likewise at 1 year. We can also see it from the p-values, which are statistically significant as well. So we had 64% of the patient had recurrence post stent insertion of these anastomotic strictures, but this time the average time to develop recurrence was 17 weeks. We had fortunately less number of serious complications, which was just 7%, like 2 patients had fistula formation and none had perforation and aspiration pneumonia, whereas minor complications were seen in 39% of patients who had stridor and stent migration. So when we compared the clinical success of stents, which were placed earlier before stricture became refractory, with those who had at least 3 sessions of bougie dilatation, it was seen that early stenting is associated with improved dysphagia score, means patient had better symptoms in short term as well as long term at 1 year. Similarly, the early stenting was also associated with less average number of procedures. However, strictures recurred earlier in late stented patients. So in one of the study by Martin and colleagues suggested that the early use of stents were associated with improved dysphagia score and less reintervention, suggesting that stents were more economical than frequent dilatations. These results are quite comparable with our study, in which we had an improved dysphagia score not only in short term but at long term as well, like at 1 year. There were fewer reinterventions which were required, and the late recurrences was seen. In a randomized controlled trial by Capelle and colleagues, compared endoscopic repeated dilatations with stent placement for anastomotic strictures who underwent 2 or more dilatation previously, and in both the groups, there were comparable increase in the interval of reintervention, and there was no difference in time of recurrence. However, there was improved quality of life in the stent group, and they also assessed this quality of life by the dysphagia score. In a multi-center study by Bazabici and colleagues showed a serious complication rate of 14% as compared to our study, which was just 7.1%. So in a nutshell, stent insertion appears to be an effective and safe treatment for anastomotic strictures. They may be considered earlier in the course of treatment because anastomotic strictures became refractory. Thank you.
Thank you, Sundas. So my first question is, a couple of your patients developed fistulas, and I believe those fistulas are probably um, um, to respiratory tract. Is that right?
Yeah,
So,
that's right.
so how do you manage those patients?
Definitely for fistula, we need another stent. And if it's our stent is not covering the fistula, we need to put in another stent.
So, what I'm understanding from your explanation that if there's a fistula, you just cover it with a covered stent. Is that right?
Exactly. Yes,
Okay,
that's right.
okay, okay. That makes sense. Thank you. Dr. Mohsin Fareed.
Yeah. So, Sundas, I have a question regarding the nutritional status of these patients.
Yes.
How the nutritional, was there any measurement or was there any improvement in their nutritional status led to their improved outcomes?
Actually, we didn't see this before stent and after stent. They had improvement in there. We calculated the BMI before stenting, and we then compare this that if this what is the effect of this BMI and the role of this BMI or their nutritional status on their on developing this structure or their dysphagia score at 1 year. We compared this thing, and we find out that those who were malnourished, they developed the anastomostic structure earlier than those who had normal weights or who were overweight. And we also noticed that those who were malnourished has worsened or bad dysphagia score or higher dysphagia score at 1 year compared to those who had normal weight or who were overweight. So nutritional status directly affects this thing, but we didn't had that thing came. It
Well, well,
improved or not.
well, I can see that why Mohsin is asking this question because Saad had a statistically significant results with his study, and obviously he's your fellow colleague, and I imagine that you guys, when you talk among yourself, you may be able to get an idea to extrapolate your study data.
Yeah.
Any other question, Dr. Mohsin Preet?
No, thanks.
Well, thank you very much, Sundas,
Thank you
for
so
this
much, sir.
intriguing work you're doing at GI Front. We're going to be signing off from our presentations. We are done with our presenters. It was very thought-provoking, intense, with a lot of information. I'm not even sure that if I can grasp all the ideas I've learned today, but definitely a lot of these things will improve our knowledge, and we're going to keep on striving for better and better. Thank you very much, Dr. Mohsin Fareed, for joining us, and we're going to sign off. Thanks a lot. Take care.
Thank you. Thank
Allah
you.
Hafiz.
Take care. Bye. Allah Hafiz.